We're continuing our discussion of the brainstem. The cerebellum is definitely a part of it. Normally I cover that last because it ties in nicely up onto the cortex, but that's all right. It's still a brainstem. We're still in it. The first part of this is going to be sort of an overview of some of the tracts that you see in the brainstem. We have some ascending tracts that head on up to higher structures. And then there's descending tracts to affect activity in the spinal cord. There's also some local tracts that remain in the brainstem to link together different nuclei there, so that, for example, vestibular input can affect the movement of our eyes without having to recruit any other structures. They create nice, simple reflexes within the brainstem. And the only way to build a reflex is to link a couple of neurons together, and that's all a tract is, something that's linking neurons together. After that, we'll go through cranial nerves 9 through 12, basically skipping cranial nerve 11. It only does something very simple. It innervates two muscles. I'll tell you about that in a bit. But if you can go like this and this, then you got it. That's all it does. There's a cranial root of the accessory nerve, which we mostly consider a part of cranial nerve 10, but it's debatable. So you could call it its own cranial nerve, or you could just call it vagus, and that's probably okay. I wish I had a better story for you, I'm sorry. That's how it goes. And it's weird because cranial nerve 11 is below cranial nerve 12, so the numbering gets thrown off. It's a mess. But it's a mess we'll clean up in the second part of this. First, I want to go over some of the tracts. Those fiber bundles that are connecting either the cerebrum with the brainstem, or the brainstem with the cerebrum, or the brainstem with the spinal cord, or itself. The first tract to talk about would be kind of the other part of our motor output. So we've covered the corticospinal tract. Cortico-bulbar tract is very similar, but not going to the spinal cord. It's going to the brainstem, so from cortex to brainstem. And this tract is going to allow upper motor neurons in the cortex to affect lower motor neurons in the brainstem. Rather than controlling the musculature of the body, these lower motor neurons will control the musculature of the face. There's a few different nuclei that we'll talk about throughout this unit. We'll definitely consider these two nuclei, so the trigeminal and facial. These are going to be responsible for movements of the face. The trigeminal nucleus deals more with chewing, as opposed to facial expression. That's going to be covered by the facial nerve. The trigeminal has the major function of being the sensory nerve of the face, but there is some motor component to it as well, and that's going to be output to muscles of mastication so that we can chew. The facial nerve is going to control musculature that deals with facial expressions. There's a couple of other nuclei that we're going to hit. So there's the nucleus ambiguus. We'll talk about this one again later on, because this houses the motor output for cranial nerves 9, 10, and 11 if you believe that it exists. So this is going to be a major output here. You can see 3 different cranial nerves, or you can just call it 2. That's still fine. 2 is pretty big. The nucleus ambiguus is going to be the major motor nucleus of the medulla. Ambiguous has an M sound in it. This is different from the solitary tract nucleus. Solitary tract is going to be sensory. And then there's the hypoglossal nucleus. So this is for cranial nerve 12. So we got 9, 10, 11, 12. That's what today is about. These will get their own lecture. Cranial nerve 12 is going to control the tongue. The innervation here is a little different from what we see in the spinal cord, at least for that lateral corticospinal tract. Everything's contralateral there, so you have independent movement of your limbs. And opposite sides of the cortex control opposite sides of the body. So this is true for the tongue. We can move different sides of our tongue independently, so you can roll it over, curve it up if you want. That's not always true, though. There's quite a bit of bilateral innervation here. For example, chewing. Chewing typically involves both sides of the jaw, so they just move together. The facial nerve is a little unique, though. Some parts of it are going to get bilateral innervation, and others are going to get contralateral innervation. And this makes it difficult for us to move some parts of our face independently. There are some notable exceptions, like The Rock, who can do the people's eyebrow, which I wish I could. And I guess with enough practice, anyone could learn, but it's really difficult to move your eyebrows independently. But you can totally move different sides of your mouth independently. Don't need any practice for that. That's because the motor neurons that control the upper face are going to receive bilateral innervation from the cortex. So regardless of which side of the cortex is active, regardless of which upper motor neurons on which side, both sides of the facial nucleus will get innervation if that part of the facial nucleus deals with the upper part of the face, so that your eyebrows and forehead are tending to move together. As you move down lower, then you only have contralateral innervation. So the right side controls the left side, and only the left side. And vice versa. Because of this, it allows us to localize lesions that occur along this tract. So whenever we see facial paralysis, you can distinguish lesions that are supranuclear, or let's say up there in the cortex, so above the facial nucleus. Because of the pattern of innervation here, the upper face is going to be spared. Because that upper portion of the facial nucleus there is going to get input from both sides. Bilateral innervation. Even though you have a lesion over here on, I suppose, this gentleman's left motor cortex, the right one still innervates both sides. So the upper face is going to be spared. You'll only see lower facial weakness in that case. Yeah?
Would it be weaker, though, in comparison to if it was innervated by both?
No. No noticeable change here. So you'll still see the typical resting wrinkles that will come for all of you someday and are arriving right now for me. If you have a lesion within the facial nerve, though, here's where you're going to see paralysis upper and lower. Because the facial nerves are going to innervate the same side of the face as where they're sitting in the brainstem. So it's ipsilateral innervation and only one side. There's no branching out here. Once we create our facial nerve, it innervates that side of the face. And so you can tell the difference between a stroke that's supranuclear or just damage to the facial nerve, which would create Bell's palsy here. So notice the forehead. Notice how he has it fairly smooth up here. There's that eyebrow droop. His wrinkles are preserved on this side. There's some lower facial weakness as well, but this is the telltale sign that we're not dealing with a stroke up in the motor cortex. We're dealing with damage to the facial nerve. The good news is that oftentimes these resolve spontaneously, and most people are going to have complete recovery of motor function within 8 weeks. Sometimes it takes longer, though. The minority of patients are going to have subtle, long-lived motor deficits. Usually this resolves them. And that's because of the funny innervation of the facial nucleus. Part of it's bilateral, part of it's contralateral. So only whenever you have lesions below the level of the facial nucleus, when involving the facial nerve, do you see this side or that side affected evenly. Anything above that, you're going to spare the upper portion of the face. So you'll see those wrinkles being more uniform across. That would suggest stroke, supranuclear lesions. We've covered this already, so this should make a whole lot of sense to us now. There's the loop between motor areas and the cerebellum and back. So within our brainstem, we're going to have bundles of axons that are connecting cortex down to the pons. Pons, of course, to the cerebellum there. So we're going to head in that middle cerebellar peduncle. We're not going to directly innervate that inhibitory neuron. We know better. We're going to hit a granule cell. Granule cells then excite that Purkinje cell. That's what the inhibitory neuron is. That's going to affect the output. In this case, the dentate. Notice we're pretty lateral there in the hemispheres. That makes sense. When our cerebrocerebellum, that's the one that's going to provide the major feedback to the cortex. So we get this big loop here, where we go from really any area of the cortex. It could be motor, sensory, it could be somatosensory, it could be visual, it could be auditory. All areas of the cortex project down to the pons and into the cerebellum. This way the cerebellum has a great idea of what's going on, not just motor plans. It needs to know a little more than that, and it does. So we go from cerebrum to pons, pons to cerebellum. That's your cortico-ponto-cerebellar tract. The cerebellum then works its magic, refines this motor plan, and it refines it by projecting back to the ventral lateral thalamus, which then communicates with the motor cortex so that the appropriate upper motor neurons are selected in the appropriate time. When you have damage, you're going to see different types of deficits. We're all aware of this at this point. We've seen this guy, so he can touch his nose with the right side. We're going to see some intention tremor, a little lack of coordination on the left side. So let's just start by saying which part of the cerebellum are we affecting? That in the middle or more in the lateral hemispheres? Yeah, so we're seeing some appendicular ataxia here. So the appendages are less coordinated. Which side of the cerebellum are we dealing with, left or right? Exactly, it's ipsilateral. You'll notice here we have a nice little double cross. We're on the right side of the cortex here. We head on down, head to the contralateral side of the cerebellum. That's going to go back to the contralateral side up there. All the innervation coming in from ascending tracts in the spinal cord stay ipsilateral. The output remains ipsilateral as well. So that's how we can tell this is in the left portion of this gentleman's cerebellum. Anything along the middle, you see this. Here we're more affecting the trunk. We're going to affect the communication between the cerebellum and the vestibular nuclei. We've seen this before. So we have our corticospinal tract pretty much, but now we call it the corticobulbar tract. We also have a version of our posterior column medial lemniscus and our spinal thalamic tract. Of course, we're not dealing with the body, now we're dealing with the head in this case. So that's going to be mediated by the trigeminal nerve. Very simple name here. You can call it the trigeminal thalamic tract. You can call it the trigeminal lemniscus. Same thing. It's the pathway from your trigeminal afferents up to the thalamus, and the thalamus to cortex. One nerve, but a couple different nuclei. So there's a motor component for the trigeminal up here. We don't care about that for our purposes. We care about the pontine nucleus, sometimes called the principal nucleus, sometimes called the principal pontine nucleus. This is where we have non-painful sensation. So here's essentially your posterior column medial lemniscus for the face. The spinal thalamic tract is going to be on this large spinal nucleus that spans from the pons on down into the spinal cord. This is where thermal and noxious stimuli are going to arrive. So your A delta and C fibers are going to innervate the spinal nucleus. And you'll notice that it's not just in the brainstem, it goes down into the spinal cord as well, hence the name. So it's going to receive input from other nerves besides the trigeminal. And that's why tension in our shoulders can produce headache. Because those afferents innervating your shoulder that reach into the spinal cord, these upper portions of the spinal cord, are synapsing under the spinal nucleus of the trigeminal. This is kind of like referred pain for the viscera, but in this case we're referring pain from our shoulder to our head. So it produces pain in the head because it stimulates your trigeminal thalamic tract. And this gives us the perception of pain in the head because we have trigeminal activity. The trigeminal innervates the head. Since the trigeminal tract is activated, the only interpretation we should have there is that there's some pain in my head, even though it has nothing to do with the head. It's a little further down south, depending on which way you lay. These secondary afferents here, either in the pons or in this spinal nucleus, those then cross over just like they did down in the spinal cord. So posterior column medial meniscus, spinal thalamic tract, trigeminal thalamic tract, doesn't matter. The secondary afferent crosses. That's still true. That secondary afferent encounters a tertiary afferent in the thalamus. That's still true. We hit a different part of the thalamus. So now we're not in the ventral posterior lateral thalamus. Now we're in the ventral posterior medial thalamus. Whether you're in the pons or in this spinal nucleus, all afferents are going to arrive there in the VPM, ventral posterior medial thalamus. If you are a part of the spinal nucleus, you're also going to hit those intralaminar nuclei to create that general arousal in response to pain. So pretty similar to what we see with those spinal tracts as well. So if you put them together, here we're looking at the posterior column, medial lemniscus pathways, as well as that trigeminal lemniscus. Pretty similar here, we have primary afferents out in the face for the trigeminal. Could be the dura, could be just the head, or out there in the body for the posterior column, medial lemniscus. Face, body. So this way we have a sense of what's going on everywhere from head to toe. These are going to run pretty close to one another and encounter pretty close areas of the thalamus. A little different though. Of course they should be different. They're arising from different parts of the body. But they have a nice relationship with one another. So it creates a little body map within our thalamus. So that the ventral posterior medial nucleus deals with the face. And that has an organization where neurons that innervate the forehead are similar to those that innervate the nose and cheeks and then your lips, chin. So it creates a body map here. So we have our head, upper, lower limbs, and different parts of the thalamus then project to different parts of the cortex so that we create yet another body map. So same thing that we saw in the spinal cord, but now we're just dealing with the face, and it's a different nerve. So the cranial nerve, of course, is innervating the face. In this case, it's the trigeminal. That's going to cross over and innervate contralateral portions of the cortex via the thalamus. Slightly different nucleus here, so VPM rather than VPL, but there's still some similarities there. Not all of our tracts are going to deal with the cortex like we've seen for corticobulbar or the corticocerebellar loop or the trigeminal thalamic tract. Some of them are going to stay local, like that vestibulo-ocular tract, for example. This just links our vestibular nuclei to gaze centers so that when we turn our head, we turn our eyes in the opposite manner so we can keep our gaze fixed. There's going to be tracts that are connecting those gaze centers to the cranial nerve nuclei. So whenever either we move our head or we plan to look a certain direction, those gaze centers are able to control the activity of the cranial nerves that innervate the extraocular muscles in our eyes. Those tracts that are remaining local here, as well as some of the descending tracts that are going to leave, form the medial longitudinal fasciculus. It's along the midline. That's how it gets that name. It runs along the longitudinal axis, so it runs along the long axis of the brainstem there, near the midline, hence the name, medial longitudinal fasciculus. There's going to be another one that's a little more dorsal. We call it the dorsal longitudinal fasciculus. The medial longitudinal fasciculus is also going to contain those fibers that are going to head on down and innervate, for example, the neck, so we can turn our head in response to sound or aversive stimuli. Or lower parts, so that we can carry out those well-patterned bilateral movements like walking, or maintain balance. So these tracts are all lumped together. Since they run near the midline, we call them the medial longitudinal fasciculus. And here they are along here, kind of color-coded, so that MLF is just medial longitudinal fasciculus. And so when we're going from our vestibular nucleus on down, well, there's your vestibulospinal tract. The dorsal longitudinal fasciculus is going to run a little more dorsal in the brainstem there, so along the back. That's going to go from the hypothalamus to autonomic preganglionic neurons, both parasympathetic and sympathetic. So while it's running through the brainstem, it can hit different parasympathetic nuclei. When it's running through the spinal cord, now we would call it the hypothalamo-spinal tract, but it's the same thing. It's just exited the brainstem, and there it can encounter sympathetic and parasympathetic preganglionic neurons. This creates that visceral response that we get in response to emotion, like anger, which maybe is what this guy's feeling. The clenched fist would suggest that. It could be fear. Those can produce similar responses. When you get frightened enough, the vagal stimulation that drops your heart rate and blood pressure can cause you to pass out. This is why some people will faint. It's because of their dorsal longitudinal fasciculus, realizing that, wow, this is really scary, and then we hyperactivate our vagus here and depress our heart rate and blood pressure enough that we just lose it. If you're scared enough, sometimes you evacuate your bowels, and that would be going all the way down to your sacral spinal cord. So your emotions can affect autonomic output, and the way that they do that is through the dorsal longitudinal fasciculus, a direct projection from the hypothalamic neurons that, remember, from lecture 12, are well connected. They get input from our cortex, they get input from our limbic system. They have a great idea of what's going on. And when we have strong emotional arousal, we get a bodily response that we really can't control. When you're nervous, your heart rate's going to go up. Maybe your tummy feels a little off because you've changed the motility in your GI tract. You have no control over that, and it happens without you being, you're aware of it once it happens, without you controlling it because of this dorsal longitudinal fasciculus. Subcortical structures, that would be the hypothalamus, are controlling directly the preganglionic autonomic neurons that produce a bodily response. So maybe your palms will get a little sweaty and your heart rate will go up. That's that feeling of nervousness. Do we have any questions on these tracts? No? Great. I notice no nervousness there. All right, let's talk about these and then we'll... So now we begin our journey through the cranial nerves. We're going to start at the bottom today, and we'll kind of work our way up, in I hope a somewhat orderly fashion. The lower cranial nerves are going to innervate sort of lower parts of the head, but they're also going to hit other parts of the body as well, because the vagus nerve is the major parasympathetic nerve. Sure, it arises in the brainstem, but it's going to hit from throat to colon. It's got a wide distribution of axons, so it's going to control respiration, cardiac function, GI motility, but it also contributes to our ability to open wide and say ah, because it innervates the oropharyngeal muscles as well. There's two nuclei that I want to get into your heads because our cranial nerves are responsible for the motor and sensory function of the head, and then some, at least when we're dealing with the vagus. So we should have an idea of the major motor and sensory nuclei. Since we're talking about cranial nerves 9 through 12, the two nuclei that we need to talk about would be the solitary nucleus, or the nucleus of the solitary tract. It has a few other names, but they all sound like that. The solitary tract nucleus is the major sensory nucleus. Solitary. Sensory. This is going to get input from cranial nerves, mostly 9 and 10, as you can see down here. Cranial nerves 11 and 12 don't have any sensory function, so they obviously can't contribute to this. There's a little bit of input on the more superior regions in that gustatory nucleus that deals with taste. Here we're getting input from the facial nerve. This is going to provide the bulk of taste sensation. So from the anterior 2/3 of the tongue, as we'll find out later, your facial nerve innervates all the taste buds there, and it's going to convey taste from about 2/3 of your tongue, so the front 2/3. The back third is going to be from our glossopharyngeal, and then that kind of aftertaste that you get in the back of your throat is going to come from the vagus. It's a minor contribution to taste, but it's important. So all taste sensation, whether it's from cranial nerve 7, 9, or 10, are all going to converge in the gustatory nucleus. And here's where we start to put together our idea of taste. There's a couple other divisions that are going to deal with respiration, blood pressure, as well as just feelings in our throat, in our airways, so that whenever we have a little bit of irritation in the throat, we cough to clear that out. You can elicit this consciously, but there's also a cough reflex, so that whenever you have a little gunk in your airway, you cough it out so that you don't bring it in and clog up the works. That's going to be accomplished by the commissural nucleus. So those cranial nerves that are innervating your throat, 9 and 10, these are going to provide sensory feedback in case there's some sort of irritation. And the commissural nucleus will elicit cough reflex. The other two are going to come up in a little more detail in lecture 18 whenever we talk about the reticular formation, which these are a part of. So the baroreceptor nucleus is going to get input from cranial nerves 9 and 10, just like every other one here. That'll help you remember that. So the nucleus of the solitary tract is going to be innervated by cranial nerves 9 and 10. Just a little bit of 7 for taste. The baroreceptor senses blood pressure in the carotid for 9 and the aorta for cranial nerve 10. So a couple major blood vessels, we're going to sense stretch in them, and that's going to be how we determine blood pressure. If there's an increase in stretch, increase in blood pressure, we're going to get a parasympathetic response to lower blood pressure. If there's a drop, we get a sympathetic response to increase blood pressure. So we get a fairly level blood pressure throughout the day. And here's how we're sensing that blood pressure, the baroreceptor nucleus, the pressure receptor nucleus. There's also the respiratory nucleus here. So here we have some chemoreceptors on the carotid, so we're going to sense blood gas levels. We'll talk about how we do that later on. But if you have a rise in CO2, maybe you should take a breath. That's the reflex here. If there's a change in blood pH, you need to respond to that. So as CO2 levels rise, this is going to stimulate an increase in the rate of respiration. You probably never give respiration much thought throughout the day. And that's because this is a reflexive circuit that doesn't involve the cortex, the cerebral cortex. If it doesn't involve the cerebral cortex, you don't think about it. So chemoreceptors out in our blood vessels stimulate neurons in the respiratory nucleus. These then form a nice reflex arc down into other areas of the medulla that will then control lower motor neurons that affect respiration. Increase CO2, increase the rate of respiration. So this way, without you having to think of it, you'll just automatically breathe throughout the day. And we know whether or not we can inhale or exhale because there's also stretch receptors in our lungs to sense, are they already full? If they are, there's no reason to try to drive further inhalation. We're going to first clear the lung, then drive a fresh round of inhalation. So you need to know both of those things. How's my blood gas? How much gas do I have in my lungs? Solitary nucleus is going to get a variety of sensory input, as we can see. Nucleus ambiguous has that M sound in it. Here's your motor nucleus. This, along with the hypoglossal nucleus, is really about all we need to talk about for today. There's going to be a little salivary nucleus for some parasympathetic output, but this is the major motor nucleus in this case. It's going to be in that kind of upper to mid medulla. It gets bilateral innervation here, and mostly what we're dealing with the nucleus ambiguous would be swallowing, breathing, talking. The things that you do typically with your mouth and throat. So the motor innervation to your oral pharyngeal musculature is going to predominantly come from cranial nerve 10. Cranial nerve 9 is going to have a very important function of opening up the throat whenever you're swallowing, so we can allow that bolus of food to move on down. And then the throat remains normally smaller than when we're swallowing here. Cranial nerve 11, if you want to call it that. This quickly joins up with the vagus, so it's hard to distinguish anatomically. They both exit together. They come from slightly different areas of the brainstem. So we call it the cranial accessory nerve. There's another cranial nerve 11. That would be the spinal cranial nerve 11. And that's going to innervate your sternomastoid and your trapezius muscles. Sternocleidomastoid, if you want to add some extra syllables. Same shit. So, nucleus ambiguous is controlling your oropharyngeal musculature so that you can talk, breathe, and swallow in a coordinated manner. You don't want to try to do all of those at the same time. I suppose with talking, you're exhaling, so it's kind of like breathing. But you get the point. Let's not be unreasonable here. Yeah?
So you said other cranial nerve 11. Should we think of those as two separate things then?
Yes,
okay.
Absolutely. The cranial portion of the accessory nerve is minor. And I think only for historical reasons it gets called cranial nerve 11. Functionally, it's inseparable from the vagus because it quickly beats up with it and runs together. It's hard to tease it apart. There's a small separate rootlet, so you can see it when you're right at the level of the brainstem, but that separation is very short-lived, and it subserves the function of cranial nerve 10 anyway. When we're talking about cranial nerve 11, anytime anyone brings up the accessory nerve, what they're talking about is that spinal portion that innervates neck and shoulder. Very few people are going to talk about cranial accessory nerve. Yeah. You can just think of that and 10 is the same, and that's totally fine. If I ever dock you on it, come yell at me. I will undock you. So, we're going to step through these, skipping the cranial nerve 11, because all that does is turn your head and shrug your shoulders. There, I just covered it. Cranial nerve 9 and 10 are the major ones here, because they are far more complicated. They have sensory and motor function. They have somatic and autonomic motor function as well. So they're kind of doing it all. These are far more complicated than cranial nerves 11 and 12. Those are simple motor nerves. One controls the tongue, one controls the neck and shoulder. The glossopharyngeal nerve, here's cranial nerve 9 for you. There's a couple different motor components here. So the major thing that cranial nerve 9 is going to do is control our swallowing and speech. So it's going to innervate the oropharyngeal muscles and help us widen out our throat whenever we need to shove food down there. There's a sensory component as well. These are also incredibly important. Some of those we're aware of. That would be taste. When you eat something, you know how it tastes. So these are not visceral afferents in this case. These are, we call them special visceral afferents. And they're special because they deal with those special senses. We consider taste special. I don't know why, but we do. Taste is very complicated. But anyway, in the posterior 1/3 of the tongue, those taste buds are innervated by the glossopharyngeal nerve. So things on the back of the tongue are going to stimulate that cranial nerve. Things on the front stimulate the facial nerve. There is no difference in the taste buds on the front or the back. Regardless of what anyone tells you, it's not true. There is no taste map on the tongue. It's all the same. We have different nerves conveying those, presumably so that we have a distributed function of taste, so if you damage one nerve, you don't lose your ability to taste things. Because that's fairly important, so that you don't eat something that's rancid, for example. Yeah.
So there's no difference between, but how do they differentiate different tastes?
Because there are 5 different taste receptors. We're not going to go into this in this class, but salty is mediated by, take a guess. How would you sense sodium?
Sodium.
There you go, yeah. Direct depolarization of taste buds that express sodium channels. So they pick up on salt. Every taste bud has a little bit of sodium channels to it, and that's why salt makes everything taste better. If you have a chocolate chip cookie, put some salt on that. It's actually pretty good. Half the sugar, double the salt. Seriously. Sugar is going to be sensed by a different type of receptor. It's going to be a metabotropic receptor, not an ion channel, because we're not dealing with ions. We're dealing with sugar. Sugar doesn't have a charge, but it binds to a metabotropic receptor and then elicits excitation of those taste buds. We won't get into that here because I don't think it matters that much, but if you do want to know more about taste, come on by. We can chat about it.
I like the
I like that. Okay, all right, we'll see. We'll see about that. Because, maybe I'm full of shit. Maybe more salt doesn't taste better. Yeah, of course you don't want too much. Right, you don't want big, coarse salt crystals on it or anything like that. But a little more salt is a good thing. Well, maybe you give up on the cookies. You gotta sacrifice. Yeah.
Maybe this is a dumb question, but do people have different amounts of each kind on their tongue?
Probably, and probably that changes throughout life, which is why kids hate vegetables. They can probably pick up on those bitter components a little more easily.
If you're still an adult, you hate vegetables.
You just haven't grown up yet. And taste is really complicated because we can acquire tastes. Like fish eyes. I don't know if that really turns me on, but it's a delicacy. I think for Eskimos or something. I don't know. That's what I hear. I've never lived with them. Anyway, let's get this train back on track here. So we're going to sense taste magically, we'll just say, or simply with ion channels and metabotropic receptors in the posterior 1/3 of the tongue. This heads on down to your gustatory nucleus and that solitary tract nucleus, and that's going to contribute to our perception of taste. We also have a sense of blood pressure and blood gas. So we're going to regulate respiration and heart rate as well with our glossopharyngeal nerve by innervating stretch receptors in the carotid and carotid bodies, or chemoreceptors. So these are going to respond to changes in pH. These are going to respond to stretch. Those allow us to sense whether or not we need to breathe and whether we need to change our heart rate in order to maintain constant blood pressure. Because your blood pressure is going to change as you move around. Your blood, like everything else, is subject to gravity. So whether you're laying down, standing up, those changes in body position are going to change blood pressure. But we don't want any dramatic changes in blood pressure to our head, because then we pass out and fall down. We'll see an example of this in lecture 18. There's some parasympathetic output as well. So we're going to, whenever we're having a meal, we have salivation occur. So part of that parasympathetic response, rest and digest, is to elicit salivation. This is going to be one of the first parts of digestion. We elicit salivation through a variety of cranial nerves. One of them is cranial nerve 9. We'll hit this again later whenever we cover our talk on the trigeminal and facial nerve. But in this case, here we're going to have parasympathetic afferents coming from up here. Sorry, we're just zooming in on this portion here. So up there in the pons, we have the inferior salivatory nucleus. Here's your preganglionic parasympathetic neurons. They're going to head on down and hit the otic ganglion. Here's where you have your postganglionic neurons, much closer to their target, like every other parasympathetic system we're covering here. And they're going to hit the parotid gland here. You spit out a little saliva and you start digestion while it's still in your mouth. So, eating, we're hitting both sides of it, kind of the motor portion here, but we're not doing the mastication, we're not chewing, instead we're salivating. Both of those are important for digesting our foods. Cranial nerve 10 is the other major nerve, because that's going to have a mixture of sensory and motor. There's going to be motor output that you control. You can say ah, you can choose when to swallow, and there's motor output that you don't really control. So we're going to have a lot of parasympathetic output here. This is the major parasympathetic nerve. It's going to go from the beginning of your digestive tract all the way to pretty much the end. The motor component is going to be for swallowing and speech, just like cranial nerve 9 here, so we're still innervating the oral pharyngeal cavity. In this case, we're hitting most of it. There's that little Cranial accessory nerve, got a question mark there. It's debatable whether or not it's its own thing. People go back and forth here. But your vagus nerve is going to be the major innervation for your oropharyngeal musculature. So it plays a major role in your ability to speak and swallow. So when you have damage to the vagus, that's why they had to say open your mouth and say ah. What they're trying to see is elevation of the palate. It should be equal on both sides. If you have damage to one side, you'll see a difference in how your palate elevates there. There's a little bit of taste down there in the back of the throat. So that aftertaste, you ever taste something, kind of breathe to circulate air throughout. That's hitting your vagus there. So we got some connoisseurs in the house. Yeah, they know what to do. We're also going to sense blood pressure. In this case, not in the carotid, down there in the aorta. But both are going to allow us to sense what's our peripheral blood pressure. Do we need to have an increase and stimulate sympathetic output, or do we need to have a decrease and stimulate some parasympathetic output? In this case, that's going to be mediated by the vagus. So that commissural nucleus, here those afferents are going to create some of the reflexes, like that barrel reflex, or the cough reflex, where something gets in your airway and you clear it out automatically. And then there's the parasympathetic innervation that's going to control lower structures. For example, your GI tract. So parasympathetic input throughout the body is largely mediated by the vagus. So there's some motor output that we can control. That's going to be up here. That's going to allow us to speak, breathe, swallow in a coordinated manner. And there's also widespread parasympathetic output. We're also contributing to taste. It's very minor. And we're also sensing blood pressure. So 9 and 10 are very similar. 10 has a much bigger footprint in the lower parts of the body and a bigger motor footprint as well. Whereas cranial nerve 9 is going to have more of a sensory function, still motor, but there it's going to have the blood gas and blood pressure sensing and a far greater role in taste than cranial nerve 10. But you can see here, very similar function. 11, the spinal accessory nerve is there to allow us to turn our head, shrug our shoulders. So you can test for dysfunction there by just measuring the strength of shrugs, if they can turn their head against resistance. Cranial nerve 12, which is going to actually innervate the face. The part that it innervates would be the tongue. Pretty much every muscle in the tongue. The vagus is also going to hit the tongue as well. But aside from that one muscle, it's all about the hypoglossal nerve. So what this does is allow you to move your tongue around. And there's input from, of course, your cortex, so you have conscious control over your tongue. But there's also some more reflexive input that allows us to move our tongue around while we're eating without having to think about that too much. Whenever you have damage to your hypoglossal nerve, you can start to see deviations of the tongue. So when they try to stick their tongue out straight, it's going to curve to one side if you have damage to one hypoglossal nerve. And that's because of that contralateral innervation from the motor cortex down to our hypoglossal nerve. This is kind of like the lower portion of the facial nerve. Only contralateral innervation, not bilateral. So whenever you have damage on one side, you'll actually see it in the tongue here. That decreased motor input to the tongue can cause it to waste a little bit. We can see that over here. This side of the tongue is wasting, and rather than being able to stick out straight, it's going to deviate toward that side. It has the lesion there.
So it deviates towards the side of the lesion?
Yeah, so the weakness on the left side is going to cause that right side to make it turn there. Now, of course, if the lesion is supranuclear, we have contralateral innervation, so it would be on the right side of the cortex, or on the left hypoglossal nerve if we're dealing with the left side of the tongue. Just we're crossing over. Now, cranial nerves 9, 10, and 11 are all going to exit the skull through the same hole, and therefore they're all compressible at the same time. There's also sinus drainage in this jugular foramen, so it's a place where you can have metastasis occur. And when that occurs and you have growth in the jugular foramen, you're going to compress cranial nerves 9, 10, and 11. In this case, when I say 11, I mean that spinal portion of it. So the 11 that everyone's talking about, not 11 question mark. And as a result, you get a consistent set of symptoms. There's going to be some subtle changes in taste, but we're not affecting cranial nerve 7, which is the bulk of our taste. 2/3 of the tongue here. And since you still have that intact and there's no taste map on the tongue, there's very little change in taste. But there is definitely a change in your ability to speak properly because we're no longer innervating that musculature as well. We've compressed the nerve and it's unable to conduct down to the musculature there. So, since we're no longer able to activate those muscles, we're going to get a little hoarseness. Cranial nerve 10 can also produce the sensation of headache as well. So aside from innervating the throat, it also innervates the dura. It innervates this skin right here behind the ear. It also innervates the ear canal. But it has nothing to do with tactile sensation or anything like that. This is all about pain. So whenever you compress those nerves, the first nerves to be stimulated are the small ones. The small ones are the ones that convey pain. Of course, the small ones are more excitable because they have that higher internal resistance. So when you push on them a little bit, they get excited and you get feelings of pain in wherever these nerves innervate, which happen to be the ear. Behind the ear, in the ear canal, so you get ear pain. You can get headache as a result of that vagal stimulation there. Speech difficulties, of course, arise. There's a loss of sensation within your oral pharyngeal tract there. And then you get this so early on you get weakness of your sternomastoid and trapezius. And then if this compression is long-lived, which it will be in the case of metastatic tumor growth, then you get wasting of those muscles, just like we saw wasting of the tongue. If you don't activate those muscles, they waste away. So you'll see unilateral wasting there in that case. Because normally you're just going to compress one side. So let's zoom in here. So here we can see all the different cranial nerves that are exiting. Here's the one that we care about. You'll notice 12 has its own little hole that it peeks out of. So here's where we're going to be zooming in right here. 12 has its own little hole, so the tongue's going to be fine, but 9, 10, and 11 are going to be all compressed together, and that's what creates this set of symptoms called jugular flame syndrome. Any questions? Alrighty, let's talk about these and call it class.